Hello, I'm Dr. Robert Brown. I'm the Vincent Astor Distinguished Professor of Medicine and Chief of the Department of Gastroenterology and Hepatology at Weill Cornell Medicine. Welcome to this Medscape social media event, Liver Logic, focus on hepatic encephalopathy. I'm joined today by Dr. Aparna Goel, who is the Clinical Associate Professor of Medicine in the Division of Gastroenterology and Hepatology at Stanford Medicine in Palo Alto, California. Welcome, Aparna.
Thank you. Thanks for having me today.
I think you're muted, Aparna.
I don't think I am. Hopefully someone can give me a thumbs up if they can hear me.
I'm still having trouble hearing you. I don't know if anyone else is.
I can hear you okay, Dr. Brown. And it looks like on sound out is okay.
Today, we're going to be discussing hepatic encephalopathy. Aparna, what is HE? Who is affected by it? And why is it so important for clinicians to be aware of this condition?
Yeah, so this is a really important question as we take care of patients that have chronic liver disease, that have cirrhosis or other portosystemic shunts. Hepatic encephalopathy is an issue with brain function, and it sort of is a reversible cause of brain dysfunction, of cognitive dysfunction that happens because as the liver blood supply or the liver function is impaired, the liver can no longer detoxify substances, the most important one being ammonia and other gut-derived toxins. And these substances can accumulate and they can affect the brain function. So it's important for physicians to recognize this early because it is reversible. And it often, untreated or even with treatment, can place a big burden on individuals, their families, the healthcare system. So just early recognition of when to suspect hepatic encephalopathy is important as well. The diagnosis is made entirely clinically. There are no great tools and blood tests, so it has to be on your radar as you're seeing a patient in your office to really be thinking about it.
Oh, thank you for that overview. Can you just discuss some of the burden that HE puts on both patients and caregivers and also on society?
Yeah. So hepatic encephalopathy probably affects nearly half of patients that suffer from cirrhosis. And because it affects function, and especially the brain function, we tend to see that there's an impairment in your ability to carry out day-to-day tasks. Can you get to work? Can you drive a car? Can you take your medications on time? So just doing these day-to-day activities may become more of a challenge that puts a burden on the caregivers to sort of take on those roles and responsibilities. And oftentimes, because of some errors that might happen with medications or because of delayed diagnoses, we do tend to see admission rates and high admission rates to the hospital and high readmission rates to the hospital. So there is this sort of perpetual cycle where we see, both the patients affected, what they're able to do in their day-to-day lives affected, their loss of work productivity, and then that subsequent burden that now the caregivers are assuming. And you can imagine that if the caregivers are assuming that burden, that there might also be this secondary, again, loss of productivity, their loss of ability to do the things that they were hoping to do. So it's sort of this, almost tandem effect that it tends to have on both patients and their families. And with the high readmission rates, we do tend to see that once a patient is admitted with hepatic encephalopathy, that the risks of readmissions can be quite high, up to 30 to 40% having a readmission within the first year, either emergency room visits, inpatient visits, emergency room visits, and that can really significantly drive the healthcare costs up as well.
Well, I mean, that it is clear we have an issue here, and we know that HE has a very broad spectrum of clinical presentation, from very subtle signs and symptoms to severe clinical manifestations, sort of the syndromes you're implying. Maybe if we talk about those in more detail and, sort of focus on how we can get to early recognition, that would be really helpful.
Yeah. So in practice, or what's in the guidelines, is this criteria known as the West Haven criteria that you can use to grade encephalopathy. And these criteria exist to quantify and to put a diagnosis in buckets. But I think that it's important to recognize that this is just a spectrum of disease. So we see that hepatic encephalopathy can sort of be in this covert phase where it's actually really hard to detect. And it can be quite a challenge to even recognize that a patient that has liver disease might have any sort of subtle signs of cognitive dysfunction. And then, apart from covert encephalopathy, you sort of have a spectrum of disease where it's more overt, where there are very, very clear signs and symptoms that our patients are experiencing. So covert encephalopathy or minimal hepatic encephalopathy is really only diagnosed if you're doing clear neuropsychiatric or psychometric testing that's in the office. There's all these really cool new tools, AI tools or apps that are also available for clinicians to use to detect if there's, changes in your reaction scores to certain testing, or even changes to your speech and the cadence of your speech. And that can sort of signal that there might be some early or covert signs of hepatic encephalopathy. And then when it starts to become more overt, the things that we start to notice in our patients are reversal in the sleep and wake cycle. So our patients will say, or their caregivers will share with us that there's a lot more daytime sleepiness, a lot more awake time at night. It's hard to fall asleep at nighttime. There's also maybe changes in mood, maybe more irritability. There might be some gait disturbances, difficulty with speech finding, or subtle changes with their speech as well. And that's when it becomes a little bit more overt, that there are clear signs of the ammonia and other toxins that are actually affecting the brain. And there, as the disease sort of progresses, and if we're not able to reverse it in time, we start to see pretty dramatic effects where there's very, very clear lethargy, there is disorientation, in very severe cases, even signs of coma. So it can be quite the spectrum. Yeah, sorry, go ahead.
Yeah, so we'll talk about covert and early in a moment, but most people are going to be diagnosed initially with overt, and that usually is triggered. So let's talk a little bit about the triggers that can precipitate an episode of HE.
Yeah. So we see this a lot. You've experienced it when you're taking care of patients in the hospital, even in the outpatient practice. But some of the most common triggers for when hepatic encephalopathy develops are infections. So any kind of infection. It could be a viral infection, flu, COVID, or it could be more severe infections that we tend to see in our patients with liver disease, like spontaneous bacterial peritonitis. Constipation tends to be a big trigger because then the ammonia levels we do start to see building up a little bit more. Medication noncompliance, so especially if there's issues with tolerability of lactulose or tolerability with titrating the amount of your lactulose or Miralax, whatever you might be taking to have an adequate number of bowel movements. If people are taking other concomitant medications that could be sedating or that could affect the nervous system, like opiates or benzos, that can very frequently be a trigger to hepatic encephalopathy. And then common things being common, dehydration or excessive diarrhea, or other things that might affect electrolytes themselves, so new water pills, diuretics, that can absolutely trigger a hepatic encephalopathy as well. There are shunts that we create to help treat portal hypertension. These are tips, and there's also naturally occurring spontaneous shunts that can happen to help decompress and resolve portal hypertension in our patients that have cirrhosis. And these shunts are also a reason why patients experience hepatic encephalopathy. So I hope that that's sort of an overview of what the triggers are. I sort of listed all these things, but Dr. Brown, when you see someone and you have someone that's coming into the office with hepatic encephalopathy, how do you suspect that they might have hepatic encephalopathy versus another condition that could be causing cognitive impairment or dementia?
Yeah, I mean, we always say that HE is a diagnosis of exclusion, and I'm not certain that is. I mean, there are things we have to exclude. Certainly, when you see someone in the hospital, we have to exclude brain trauma and brain imaging, et cetera, is important, particularly for patients who are massively altered. But to me, it is a clinical diagnosis. And so you have to start, do they have cirrhosis and portal hypertension? So if a patient has cirrhosis and portal hypertension, that's going to be something I'm going to think about. If a patient has minimal portal hypertension, it's probably not HE. And so I see all sorts of patients who are diagnosed with HE based on an elevated ammonia level without any significant portal hypertension. So it's important to know that blood ammonia is part of the spectrum of HE, but it doesn't add really any value in diagnosing patients with HE. And I see patients who are put on lactulose all of the time based on an elevated ammonia level. And maybe they have normal mentation, or maybe they have dementia. But I think the key thing is, one, as you highlighted earlier, we're going to hopefully start to use better tools to diagnose early HE, covert HE, using AI and other tools, but they have to be easy to implement in clinical practice. Two is we have to remember that HE overall is a problem with the level of attention. So if patients are just forgetful and they don't have sleep-wake disturbances, they don't have the other signs that are compatible with HE, you should think about other causes of mental that are affecting their mental faculties. And then finally, I think that if all else fails, it is reasonable to do a short trial of HE therapy. So I have patients who tell me they have sleep-wake disturbance. I give them a month of HE therapy. And if they get better, I think I've made the case. So ammonia is occasionally helpful when it is normal in a case that seems very atypical for HE, or maybe if it's very high. But generally, I don't use ammonia. I do a careful assessment of both their level of consciousness as well as their level of orientation. And I think the more we identify it early, the more likely we are to be successful with this.
Mm-hmm. Yeah, I think that's a really important point, that it's a clinical diagnosis and that we don't have a real clear definitive test right now, and ammonia has its limitations. So we're not necessarily relying on ammonia levels at all. Do you screen your patients in any one particular way for hepatic encephalopathy in your office?
No, I think the problem is it's really too time consuming. If I have to do one test, I like the animal naming test because it only takes a minute. How many animals can they come up with? But generally, I don't. I think that some of the research that both people in our group, Dr. Buchholz and other people are doing at looking at using wearable technology to try to make earlier diagnoses, I think is going to go a long way. Or perhaps we can get to a point where patients, test themselves at home before their appointment. You could imagine that during your check-in, you could probably do the Stroop or some other test. But I just think that in a busy clinical practice, it's really hard. But I do ask certain questions of every patient. And I think that what you highlight about sleep-wake, really important. And also tasks that used to be easy that are now hard, whether that's the New York Times puzzles or it's balancing their checkbook. Things that require concentration, I think, are really important. But we could go on for hours about this. This has really been fun, but I think that you really have highlighted some key takeaways. One, the importance of HE, both as a morbidity and mortality, both for the patient as well as their caregivers and society. Two, the spectrum of disease that we really focus currently on people with, severe disease who are presenting to the hospital with confusion, even coma, all of which is driven by a precipitant, usually infection. I think tends to be overuse of lactulose, probably more common than underuse, and the need to work towards earlier diagnosis, hopefully using new technology, but not using serum ammonia. So I hope this has been a great discussion for me. I hope you've enjoyed it as much as I have. And more importantly, Aparna and I hope that you enjoyed this Medscape social media event. Please use the link below to claim your credit, and I hope to see you next time.
Bye.